Professor Desai. He is the past president of the American Academy of Dermatology. He is also an expert in pigmentary disorders, including vitiligo. And he's going to tell us the new things in vitiligo. Thank you very much for being here.
Muchas gracias, buenos días. Muchísimas gracias a Yolanda y Isabel y todos los directores de AEDV. Es un honor desde en España. Esperamos el próximo congreso yo puedo hablar solamente en español, pero hoy yo hablar en inglés. And thank you so much for the honor to be here again in Spain for Professor Guilaberte, Belinchon, and the entire AADV board. It's a true pleasure to be back in Spain, truly one of my most favorite countries in the world. Over the next few minutes, I'm going to give you an update on some of the new things that are happening in the world of vitiligo. And I hope that by the end of this talk, you'll be able to think about new horizons, because one of the things that I think is so important to tell any of our patients with vitiligo is there is so much hope on the horizon with new treatments that are soon coming. When I was giving vitiligo lectures 10 years ago at the AAD, many of us were speaking about the same therapies, phototherapy, topicals, maybe some off-label orals. And now, 10 years later, we have so many new things that are soon to come. So one of the most important things I think we must give our patients is hope for a cure one day for this disease. These are my disclosures. I have no relevant conflicts of interest to this talk. So when we think about therapies in vitiligo, we have a very large therapeutic armamentarium. Many of the things that we've already talked about in this excellent session are still part of what we do for this very tragic disease. One of the things that I think is also important for us to understand is that vitiligo is not a monotherapy disease. Most of what we do in the world of pigmentation requires a polytherapeutic approach. And even with the new therapies that I'm about to share with you, one of the things that I think is important to understand is that none of these treatments should be used isolated just on its own. For most patients with vitiligo, a combination therapeutic approach is essential. Now, before we talk about some of the new things, I thought I would also give you some new pearls into what we do for patients who come in with very, very unstable vitiligo. And one of the things that's very important that I tell my residents and also at many of the meetings where we speak together is that no matter what treatment you do for your vitiligo patient, the first and most important thing at every visit is to assess for stability. Because if you have a patient with unstable disease, then using any of these treatments is going to be challenging without knowing how fast the disease is advancing and for the need for stability. So there's 4 main clinical signs that we use in my clinic and that I teach our residents to look for disease activity. Most of these things you can do within the first 2 to 3 minutes of the consultation. This does not take a very long time. So we look for a variety of different clinical features when assessing therapies, but when we look for stabilities, some of the most important things we look for are either trichrome morphology or confetti-like changes, looking at fingertip involvement. If you have involvement and full depigmentation of all 10 fingertips, that is a marker for very unstable disease and usually a poor therapeutic prognosis. And then finally, for those patients who come in and say, yes, my disease, I've had it for many years, but now in the past few months, I've noticed a new area of hypo or depigmentation on my neck, and then I have a small new area on my abdomen, and maybe one on my leg or my thigh. And if those areas add up to approximately 1% of the patient's own body surface area, within about a 6 to 8 week period, 1% spread is a marker for unstable disease. So these are just some clinical examples. This is an Indian patient who came to see me. The patient, within the first few minutes, I don't even need to ask too many questions because I can immediately see that this patient has unstable disease. The picture on the left, you notice the confetti-like changes. It almost looks like snowflakes that are on the skin. And then on the picture on the right, on the other part near the bicep, you can also see the trichrome-like disease. I hope everyone can see the different shades of pigmentation that are noticed. Here's another example of a patient who came in with limited body surface area. This was the only patch of vitiligo on this patient. No other involvement. This is in the presacral area, right above the buttock. But even with minimal BSA involvement, this patient still has very unstable disease. This is one of the nicest examples of trichrome vitiligo that I've seen in my clinic. And even with one small area of involvement, when you see trichrome changes, regardless of BSA involvement, you must think of stabilizing this patient before you move into full assessment of repigmentation success. So when we think about stabilizing, one of the most common things we do in our practice is to use oral mini-pulse systemic steroids. So your patient with trichrome disease or confetti or Kebnerization or expanding BSA, you must stabilize them. And the best way to do that is usually by using oral mini-pulse systemic steroids. Oral dexamethasone, 4 milligrams a day, 1 on Saturday and 1 on Sunday. And we usually do this for a combination of about 8 to 12 weekends. I usually say take 2 pills a week, and these patients tend to do quite well. And as you know, dexamethasone actually has less systemic side effects than even prednisone. And so we do this quite a bit. Our colleagues in India have been the first to really publish this many years ago, and now this is something we do every day. You heard earlier in the excellent melasma lecture about polypodium leukotomas. Polypodium leukotomas is not only excellent for patients with melasma, but I also give this to my patients with vitiligo because we know of the importance of reducing reactive oxygen species and to help as an antioxidant in repigmentation. Oral polypodium leukotomas, usually once to twice daily, can improve the rate of your narrowband UVB efficacy. And finally, we also use lots of alpha-lipoic acid as an oral antioxidant as well in our patients with vitiligo. So let's say a patient comes in the first few minutes, you're looking for stability, you're assessing their BSA involvement, if they have confetti change, trichrome, etc. We're going to use oral polypodium leukotomas. I'm going to give them oral alpha-lipoic acid. I'm going to prescribe them oral mini-pulse systemic steroids, all in combination to stabilize the patient before we even look for repigmentation success. So with that, let me tell you a few of the new things that are happening in the world of topical treatments. So these are some pearls related to topical therapies. This was a consensus paper that we just published with a group of vitiligo experts around the world in JAMA Dermatology, looking at a consensus-based approach for treating pediatric patients. And one of the things that we insist that you do for your younger patients with vitiligo is to not only think about body surface area involvement, but incorporating topical JAK inhibitors even earlier in the disease course, even though we know that the FDA approval for topical ruxolitinib is for ages 12 and above. Based on our consensus, we do use this off-label in our younger pediatric patients. And I think many of you know that JAK inhibitors have become a revolutionary change in our therapeutic armamentarium in treating vitiligo. This is from our paper in the New England Journal that was published that shows that JAK inhibitors, specifically in vitiligo, work because blocking JAK1 and 2 signaling helps to downregulate interferon gamma, which subsequently shuts off the melanocyte destruction. Now, a few years ago when we were talking about ruxolitinib, we were saying, yes, it's a topical, you use it twice a day, limited BSA involvement, and it should work fairly quickly. Within the first 4 to 5 months, you should see improvement. Now, we're changing our recommendations for using topical JAK inhibitors. Now what we're saying is that even if you don't see results in the first 4, 5, 6 months, you must continue the treatment. Topical JAK inhibitors in vitiligo work much different than topical JAK inhibitors in atopic dermatitis. These are some examples of patients that I'm going to show you from our longer extension study. This was a patient who in the first year of using topical JAK inhibitor had very minimal facial VASI score improvement. But notice by the end of 2 years, she has almost full repigmentation. This was a patient who for the first 6 months in our study was only on vehicle. And the theory initially was if you don't treat vitiligo aggressively early, it's going to be much harder to get the pigment to come back. Now we know that even for the patients who come in with delayed onset treatment, the more aggressively you treat the patients and you continue, you can see nice therapeutic outcomes. So this was a patient who had no exposure to topical JAKs for at least 1 year, but by the end of 2 years had almost full facial improvement. This was a patient, a young patient with large areas of involvement on the posterior thigh. For the first year of the study, she had no improvement. Now you imagine a patient like this comes to our clinic, the parents are going to be worried, you're going to have frustration, they're not going to be happy because nothing is working. Many of the things we do in vitiligo require you to coach the patient to remain optimistic that the treatments will help. And this patient, by the end of 2 years, had a very nice improvement. Acral vitiligo, as you know, on the hands is very, very, very difficult. But with topical JAK inhibitors, we also see nice improvement. Just one caveat. The dorsal hands and the digits respond fairly well. Fingertips do not respond very well at all. And unfortunately, tip involvement is very, very difficult for our patients. Now, finally, in the last few minutes, let me tell you some of the new other things that we're doing studies on now. This is a study we're doing in our practice on a brand new mechanism. This is not a JAK inhibitor. This is an intranuclear blockade of the BET protein. And BET, as you know, is a transcription-based cofactor that stimulates gene transcription. JAK-STAT works very differently. BET works in the nucleus. And so now we've been studying a new topical therapy that's actually shown to prevent melanocyte migration and detachment from its keratinocyte friends in the upper part of the epidermis by blocking BET in the intranuclear level. So what we found is that with this topical therapy, once daily use of this BET protein can give you within about 4 months a very nice clinical improvement once daily topically as non-JAK inhibitor. So this is another novel concept. This is another patient who came in who has confetti-like changes on the perinasal area and involvement in the upper part of the scalp. You can see that by week 16, a nice therapeutic outcome with a once daily topical that's not a JAK inhibitor. So you'll be seeing more of this in the coming months. Finally, let me finish in just another minute with giving you what's new in oral JAK inhibitors, because this is something that by the end of 2025 into 2026, I'm hopeful that we will finally have FDA approval for oral JAK inhibitors, not just for atopic dermatitis and alopecia areata, but in vitiligo as well. Oral upadacitinib, we've just concluded the phase 3 study, soon to be hopefully FDA approved, 15 milligrams once daily. This has been published off-label already. Oral povorcitinib is also now in FDA study, phase 3. There's 3 oral JAK inhibitors that are racing to the finish line. Upadacitinib, povorcitinib, which is now in phase 3 for vitiligo and for hidradenitis suppurativa. And then, of course, you know about ritlecitinib, which is FDA approved for alopecia areata. Hopefully soon will also be FDA approved for vitiligo. So now, 10 years ago, we had nothing FDA approved for this disease. Now, within 1 year, we may have 3 oral therapies. We have 1 topical, a new topical coming, and so much more hope for our patients. Lastly, let me show you this video, and then I will finish on autologous stem cell transplantation, which is also something new that I hope we will get to talk about more at our next meeting together. I'll show you these videos. This is something that can be done in the office where you use a small dermablade, you take a small sample of your unaffected skin, and then what you can do is prepare a suspension in your office, and then ultimately you apply this directly on to the recipient site of vitiligo. And this is very, very, very helpful for our patients with segmental disease. This is just a before and after showing a very nice improvement. So in closing, let me just say that in a world of Instagram and TikTok and social media, we finally have more destigmatization for our patients with vitiligo. You know many of the famous people on this slide. And I hope as we continue our journey in vitiligo, we'll be able to embrace new therapies to give our patients the hope that they deserve. Muchísimas gracias.
Thank you very much, Simal. Any question? Professor Alomar? Professor Alomar is one of the main experts in vitiligo here in Spain.
How the studies are so reluctant to use phototherapy combined with ruxolitinib, because there is several presentations also in Cairo was presented a result, and the changes after starting phototherapy was very, very impressive. I always believe that melanocytes needs light to be stimulated.
Thank you for this excellent question. I completely agree with you that phototherapy is something that is incredibly important in the treatment of our vitiligo patients. Yes, to your question, ruxolitinib, in practice, we use it all the time in combination with narrowband UVB and with excimer laser. And for most of my patients, over 80–90% of my patients who are prescribed a topical or oral JAK, I use phototherapy in combination because absolutely it works better. The one thing I do want to say is that in the studies, the data is done as monotherapy. And so for patients who either cannot afford phototherapy, they cannot come to our offices, it's very inconvenient, yes, you shouldn't withhold JAK therapy because the patient does not want to do phototherapy. But when you do it together, it totally works much better. And now there's a new study that's being published on the synergistic effect, just to your point. So yes, I completely agree with you.
Just a point. In Spain, we have a sunny country, and then sun exposure, 3 minutes, works perfectly as phototherapy.
I completely agree. Absolutely.
Your talk is that we should maintain the treatment because we hope that maybe with JAK inhibitors, the treatment would be shorter, but it's very important to maintain 2 years.
Thank you, Yolanda. You're absolutely right, because these patients respond slowly. These patients are very frustrated. We, as the dermatologists, we are frustrated in many of these visits, and it's a matter of continuing to cheer for the patient that keep going, keep going, keep going. And this data is brand new, because before we said, in 6 months, if you see no response, it's not gonna work. So stop and you move on. But it now is the opposite. You don't see 6 months response, keep going. Absolutely.
Okay, so thank you.
Thank you.
Thank you.